Hi, my name is Ben DeVos, Marketing Associate at Unbound Medicine. Welcome to today's webinar, where Dr. Christopher Hoffman and Dr. Glenn Treisman will discuss HIV prevention involving PrEP in 2025. This webinar will unpack essential strategies for primary care providers, mental health specialists, and substance abuse clinicians who are uniquely positioned to expand PrEP access and help combat the HIV epidemic. Now, let me introduce our speakers. Dr. Christopher Hoffman is an associate professor and clinician scientist in the Division of Infectious Diseases at the Johns Hopkins University School of Medicine. He attended medical school at Oregon Health and Sciences University, followed by an internal medicine residency and infectious disease fellowship at the Johns Hopkins Hospital. He is an HIV and general infectious diseases clinician providing outpatient HIV primary care and inpatient infectious consults. His research is focused on HIV diagnosis and care delivery to marginalized populations, primarily in Southern Africa. His has been funded by grants from the NIH, USAID, US CDC, Global Fund, and the Bill and Melinda Gates Foundation. He is involved in clinical education as the director of the Johns Hopkins New York State Department of Health AIDS Institute HIV Guidelines Program and the editor-in-chief of the Johns Hopkins HIV Guide. Dr. Glenn Treisman is the Eugene Meyer III Professor of Psychiatry and Medicine at the Johns Hopkins University School of Medicine. He is the director of the AIDS Psychiatry Service and the Johns Hopkins Pain Treatment Program. The Pain Treatment Program provides care for chronic pain syndromes and is the national referral resource for patients with intractable pain. He was the co-founder and co-director of the AMOS Center, a program that studies atypical GI disorders and the relationship between food, the nervous system of the GI tract, the microbiome, and disease, and is now the co-founder of a new multidisciplinary clinic for dysautonomia. Dr. Treisman is involved in the care of psychiatrically ill HIV-infected patients and has been since early in the epidemic. Unbound Medicine is the publisher and distributor of the Johns Hopkins Pocket Guides, which includes the Johns Hopkins HIV Guide. If you'd like to try a 14-day free trial of the Johns Hopkins Pocket Guides, scan the QR code on your screen. Dr. Hoffman and Dr. Treisman will be answering questions live following the presentation. To ask a question, please type it into the chat or Q&A box at any time. Okay, now I'll turn it over to Dr. Hoffman and Dr. Treisman.
So thanks, Ben, and thanks to all who are joining this webinar. Welcome to our discussion on PrEP. Glenn and I really felt it's important to try to get more of the message around using PrEP and approaches to maintaining patients on PrEP and engaging them on PrEP to primary care providers, mental health providers, and others who are not typical HIV providers. I'm going to get started with just a brief discussion of the epidemiology of HIV in the United States and globally currently, especially HIV incidence. In the US, there are still several thousand HIV infections annually. There are various pockets around the United States with higher incidence. Overall, it's highest among men who have sex with men, as well as transgender women, and especially among minority populations, African Americans and Latinos. That said, there are other places where there's infections, including in pockets of injection drug users, women who have sex with men, and other areas that individuals may be more marginalized with less access to information and HIV prevention. There are, fortunately, increasing tools for HIV prevention that have moved from education and condoms that remain very important to PrEP, pre-exposure prophylaxis, as well as PEP, post-exposure prophylaxis. Here we'll focus on pre-exposure prophylaxis, or PrEP. And the initial regimen that was developed was tenofovir, disoproxil fumarate, or TDF, combined with FTC, or emtricitabine. And that was an oral regimen that is taken daily and is highly effective if taken daily. but has some downsides that we will get to later. In addition, there are newer medications, including cabotegravir, which is an injection that can be used every 2 months, which is also highly effective, and a new medication that is expected to be approved within the next couple of months, lenacapavir, which is also highly effective. Any one of those, when used as prescribed, reduces the risk of HIV around 95 to 99%. Some of the nuances of each of those medications and management of those medications, including testing before and during treatment or preventive treatment with any of those medications, we'll discuss a bit more after we get into some of the issues around getting the right people these medications. So, sorry. So Glenn, over to you in terms of engaging, why we can't, sorry. Glenn, over to you in terms of getting the right people access to PrEP.
Yeah, I think that epidemiologically, the problem that we have is the people who know how to use PrEP are treating patients with HIV, and those are people who are already infected. The populations who need PrEP are largely clinically less accessible. So if you look at gay men who have sex with men and who are engaged in high-risk sexual behaviors, they tend to come into emergency settings, health departments, doctors' offices with sexually transmitted diseases and completely unrelated medical problems. And when they're young, they don't use a lot of primary care. And so that they're a difficult population to access. People with injecting drug use who are at very high risk for infection see more providers, but the providers they see are generally people who are substance abuse directed providers, and they don't know a lot about PrEP. And some of them are uncomfortable with learning how to use it. Turns out it's a very easy thing to learn how to use. And so my push is to try to get people using PrEP who are seeing patients that don't have HIV infection, but who are at risk for HIV infection. And that means you have to do three things. One, you have to know the person's at risk, so you have to take a history and understand the risks. The second thing you have to do is engage the person so that they will see you regularly. And then the third thing is you have to keep them engaged. One of the problems we have with all forms of PrEP, but particularly with the kind of PrEP that we're talking about giving as injections, is that you want to keep people on it because you don't want people to develop HIV in an environment where they develop resistance. So if there's low levels of drug around in your blood, the virus tends to become resistant to antiviral drugs. So we have to struggle with that. We also have to struggle with what medical knowledge people need to use PrEP. And I thought that when tenofovir and TAF were really the two mainstays of PrEP, they're pretty easy because if people go off of those, they're out of your blood fairly soon. And if you take them every day, you're virtually 100% protected, virtually, not quite, but pretty close. And the big problem are people who go on and then off them intermittently. The more engaged people are and the more they know and the more you educate them, the more likely they are to stay on the medicine. But we know that, and I'm going to ask you to talk about this for a minute, we know that injectable drugs are much more effective for populations of people who don't take oral medicine every day. And so using these injectable drugs is going to require that people learn how to do it and have a person who can do it that they work with. You want to talk a little bit about, just a little bit about the injectables and the assets and vulnerabilities of the injectables?
Sure. So first, as you pointed out, the oral daily medications, the tenofovir alafenamide or tenofovir disoproxil fumarate combined with emtricitabine, TAF, or TDF plus FTC, are most effective if taken daily. Recent data from the Purpose 1 study, which looked actually at lenacapavir, but compared that to each of those oral regimens, identified that even partial adherence to the oral regimen reduced risk of HIV. So I think that's the number one thing. Taking PrEP from a harm reduction perspective, the goal is to reduce, if not fully eliminate, the risk of HIV. And I think we can look at that also in terms of the risk associated with some of the injectables, the current injectable cabotegravir and the upcoming injectable lenacapavir. Both of those are effective for intermittent dosing. The cabotegravir every 2 months, the lenacapavir, when that becomes available for PrEP, every 6 months. They're both effective because they have very long half-lives in the depot formulations. But as a result, as you mentioned, Glenn, there's the long tail. And to be
Chris, tell them just a little bit what you mean by a long tail.
Oh, yeah, thanks, Glenn. So over time, the levels of these drugs go down, and probably for both of them, they're clinically effective in preventing HIV beyond the either 2 months or 6 months for cabotegravir or lenacapavir. But eventually, the levels become too low to prevent HIV acquisition, but still high enough for interference with some level of HIV replication, which promotes the development of specific mutations within HIV to overcome the selective pressures and develop resistance. That resistance then can be permanent. And for cabotegravir, which is a integrase strand transfer inhibitor, similar medication to what's in bictegravir or dolutegravir, 2 agents used in HIV treatment. With similar resistance patterns, it can lead to then later failure on those regimens. So that's certainly an important concern. To date, there has not been a lot of experience with failure with cabotegravir, partly because the use is still relatively limited for PrEP, and certainly for lenacapavir, which is only in clinical trials. There's also not a lot of experience with failure during that tail. However, both of them in the clinical trials, there are situations with missed doses or delayed doses or low serum concentrations in which HIV has been acquired and drug resistance has been identified. So those are certainly concerns. Glenn, how would you talk to your patients, or how do you talk to your patients on cabotegravir about that concern?
Well, I mean, the patients that I most push for PrEP are substance abuse patients. They're seeing me for substance abuse, although I have some psychiatrically ill patients who are at very high risk because of sexual practices. I talk to them about oral PrEP in the pill form initially, because it's difficult to get cabotegravir yet for patients. It's difficult to get them injected with it, and it's difficult to get the drug approved. I think that won't be a problem in the future. But right now, the easiest thing for me is to give them 1 pill once a day in the form of, a single pill combination. I talk to them about the risks of going off it and on it. I talk to them about the 2-1-1, which you haven't talked about yet, but is a situation where you have people take 2 pills and then 1 pill the next day and 1 pill the day after that at the time of exposure. And the idea is it's sort of like PrEP, but a little bit of PEP mixed in. So it's pre-exposure and post-exposure prophylaxis, try to decrease risk. Some people are willing to take a pill every day. Since I want them to take pills every day for their mental illness, and even the patients I'm seeing for substance use, they're usually on an antidepressant medication, since that's who I tend to end up seeing. Getting them to take yet 1 more pill to prevent HIV is not usually a big issue for them. Many of them say HIV is not a big problem for me compared to getting heroin every day. And over time, part of the psychiatric treatment is to get people to recognize that prevention is a very useful thing, and that's one of the things we work on. A large group of our patients respond better to rewards than consequences. So as a group, doctors are consequence averse. We're worried about the bad things happening. Many of our patients are reward seeking and are directed at getting what they want now more than they are avoiding consequences later. And that's really good if you're going to be a CEO of a corporation or a rock star or run an aggressive business or be a salesman. That those people make the world go round. But that same asset in those settings can become a vulnerability when it comes to thinking about future and avoiding consequences. Because they're reward sensitive, one of the rewards that becomes important to our patients is how we interact with them and getting access to us. Most of my patients want more access rather than less. They want to see their doctor more, and when their doctor sees them, they want a positive experience. By getting them to take PrEP and praising them for taking PrEP, it's very reinforcing for a lot of patients, just like I reinforce them for being substance-free and taking other medications I want them to take. And so I talk a lot with patients about how much they've accomplished and how much progress they've made when they're doing well. And scaring them into taking medications is less useful for most of my patients than it would be if my patients were all accountants, physicians, and lawyers who tend to be future focused and consequence averse. So understanding that about your patients, spending a lot of time with them to encourage them and engage them in treatment is rewarding for them and will help shape their behavior. When people come in and they're sober, I make a big fuss over it. When people come in and have a lapse, I say, you had a lapse, it's not a big deal. I go on talking now about strategies for being sober again. And I focus most of my energy not on what they did wrong and how things could go wrong, but instead on what they're doing right and how things could go better. That's not native for most physicians. Most physicians are thinking about consequences. So engaging patients and talking about PrEP is talking about the future, positive things, help protect the people that are in their life, helping to protect them, pointing out to them that a healthier life allows you to have a better sex life. Being physically well allows you to have more options, makes you feel better. And that's a very important thing. The other thing is depressed people have very poor adherence to medications. A lot of studies from the old days show that people with depression are much more likely to fail their HIV treatment. And people who don't have HIV yet are more likely to fail their PrEP. So if you're depressed, you want to treat the depression. And that often is something that doesn't get addressed as well as it should by primary care physicians and people in emergency rooms and people in urgent care settings where they may be focused on one thing about the patient, but they don't generally see the whole patient. But if you have gonorrhea and you don't have HIV, you're at risk for HIV. If you have endocarditis, you don't have HIV, you're at risk for HIV. So connecting those is very important in our medical system, and how we're going to reward physicians is very important. My son said, when we were talking before this just now, said it'd be great if you could get people on board with the energy to try to prevent HIV. I said, probably be great, but also if they got an extra $10 for every person they put on PrEP, that might be just as effective. It's certainly just as effective for the patients. That is, if you reward them for taking medication, they do much better. We have several studies showing that you can pay people to be sober and their drug use drops off enormously. The same is true with PrEP, rewarding people. If you can't give them money, you certainly can give them praise, attention, and time. I want to go back to you for a minute, Chris, to talk a little bit about what you see as resistance in your patients when you're trying to treat them for PrEP. What are the problems that I can help you overcome?
Well, I think just the rewards versus consequences is, as you said, a little counterintuitive to a lot of physicians, and certainly just in terms of the PrEP literature, about 40% of individuals who start PrEP stop within 6 months. So there's only about 60% persistence at 6 months, and at 12 months it drops off even more. And one of the reasons that's often given is that individuals on PrEP no longer feel that they have a risk for HIV, or are, and often are not very good assessors of their HIV risk. And how do you address a patient who says to you that they no longer feel that they're at risk and are no longer interested in PrEP, when you see that there may still be reasons for them to benefit from being on PrEP?
Yeah, I talk about health and positives and better sexual functioning and better medical functioning, but mostly in the HIV clinic, the people who are not cooperative are referred to our group. And the overall HIV clinic at Hopkins, the Bartlett Clinic, has very high rate of people on antivirals and a very high rate of undetectable viral loads, much higher than most clinics. And I think that's because if people are not doing well, rather than kicking them out, we engage them more. We try to bring them into the clinic more. I have patients I see every week or every other week. And if people are ready to stop PrEP, I try to see them more and discuss what they're getting out of our treatment that is good for them. So just yesterday, I was talking to a patient about the fact that he still has this problem and that problem and this problem and that problem. And I pointed out all those problems are for when he was using drugs, but all the new things that are in his life that he's accomplished in the last few months, now has a permanent place to live. He has a girlfriend. His talking to his family again. His family had sort of ostracized him, and now he's back in a relationship with his family. And I point out to him that those are accomplishments that he's accumulated. And I say, and it's by doing things like taking PrEP, by doing things like taking your HIV medicines, by doing things like taking care of your health, that those things are happening. And if you put those things together as a part of a larger picture of the new you takes PrEP. The new you has a place to live. The new you has a girlfriend and has a relationship with your family. The new you takes your blood pressure medicine. The new you doesn't drink only soda and eat only hot dogs. All those kinds of things. And look how far you've come and how much you've gained from that. And the other thing is people drop out, try to get them back in. It's a very interesting thing. Hopkins did a study years and years ago of trying to get doctors interested in addiction. And what they developed a curriculum, and people got more and more interested in addiction. And they said, when I graduate from medical school, I'm going to treat addiction. And then as you look down the road, people get less and less interested in addiction. And that's partly because of the nature of doctors. You see the people you fail with rather than the people you succeed with. And so you say, well, all these people relapsed to drugs. No, a bunch of them didn't relapse to drugs. You just never saw them again. And so you don't see your own effectiveness, and you start to feel ineffective. Whereas if you keep people in the long run, they come back into treatment also. And you can get better and better and more effective over years. I have patients who've been my patients now for, I don't want to mention it, but 37 years, who have come in and out of treatment over and over again, but now are deciding to take it very seriously and are doing great. And each year, more and more people move to that camp if you stick with them. They get discharged, they come back. If they drop out of care, they come back. And you sing the same song when they come back, which is, this is about the health of the whole person. And one of the things we do for the health of the whole person is these kinds of things, preventive strategies. So my non-HIV infected patients with substance use, they're almost all on PrEP. They almost all use needles, and they almost all share needles, and they almost all are on PrEP. And as they get onto methadone or onto buprenorphine, they often say, "Do I still need PrEP? I'm not using needles anymore." I say, "Yeah, but you still hang around with a lot of people who use needles, and I think that you should stick with it for the moment because it's part of your recovery is to be thinking about how to be healthier, and that's a way to be healthier. And eventually they can come off, but getting them to do things that are positive for them is very useful. I think that physicians burn out on that because they're not given enough time to do that. It's an important part of what we do with our patients.
Yeah, definitely. So certainly PrEP can be time limited for many individuals where they're at high risk. What I try to do, or what I do with patients that are less interested in PrEP over time, or feel that they're at low risk, either because they are no longer in a relationship they were in, or are in a new relationship that they consider stable, is encourage them to think about the 211 that you mentioned already, which is 2 tablets of tenofovir disoproxil plus emtricitabine in a single dose pill taken together prior to potential exposure, and then 1 tablet the following day and 1 tablet the day after that. There's only one study that has compared that in a RCT, which was exclusively for men who have sex with men. However, from pharmacologic studies suggest that should be effective also in women who have sex with men, and likely general use in terms of people who are at risk for HIV. In addition, as I mentioned, even intermittent use of PrEP when it was prescribed and taken daily among women who have sex with men reduce their risk of HIV. So for those individuals who feel that they don't want to take PrEP or feel that they're at low risk, I encourage them to have a bottle of tenofovir emtricitabine at home and remember that it's there, and to, if they change their practices or feel like they may have higher risk, to remember it's there.
I think that's a very useful thing. The other thing is that my patients early on have a tendency to pick bad choices for relationships. That's kind of what they're programmed to do. And as they improve their relationships, I point out to them that their partners will be more engaged with them if they know they're trying to protect them. And so I point out that they're protecting not just themselves, but other people by taking PrEP. And they often don't think about that. And it helps them to think about that. I say, don't you want to wait for the person that you're going to want to be with longer? And if you're with that person, don't you want to protect that person? And they're often, that helps them a lot to think about things, that there are other people involved. My one patient said, "Yeah, I decided I better take PrEP because if I die, no one will take care of my cat." And I've gone back to that over and over again with this patient, and the patient stays on prophylaxis because there really isn't anybody to take care of the cat. The cat, my patient gets sick, goes in the hospital, there'll be nobody to take care of the cat. And I think that those are things that you can help people think about.
So I was going to just mention a little bit about monitoring PrEP. So certainly PrEP is easy to prescribe, and currently insurance nationally covers PrEP, and in some states there are specific state laws regarding PrEP availability. So for individuals who have insurance, coverage is usually fairly straightforward. So just from a initial barrier, at least to oral PrEP, that is generally not a huge barrier. In terms of the medical side of it, from a provider, the number one thing is to test for HIV to make sure that somebody is truly not living with HIV before starting PrEP. It can be either a laboratory fourth generation HIV ELISA, that is an antigen antibody test. That's the standard HIV test that is done in laboratories today. Or that combined with a HIV RNA test if somebody has recent exposure. If somebody has frequent recent exposure, then it's generally recommended, even after starting PrEP, within a few days to a week, to repeat the antigen antibody test just to rule out a false negative initially. After that time, then approximately every 3 months, it's recommended in most guidelines, CDC and others, to repeat HIV testing with that fourth generation HIV antibody antigen test, the standard laboratory HIV test. In addition, for individuals who are on cabotegravir, there are the current recommendations are to do an HIV RNA test, at least during the early time after initiating, possibly at each injection time, which is every 2 months, up to 6 months on cabotegravir, because the suppression of HIV replication can prevent antibody formation and also keep the antigen levels below the level of detection of the fourth generation standard HIV antigen antibody test. While it remains in guidelines beyond that, there's some controversy of whether it should be HIV RNA testing should be continued beyond that point for 2 reasons. One is, if somebody's actually getting cabotegravir, it is so effective, the risk of HIV infection is extremely low. And the second is that the chance of a false positive is much higher than a true positive HIV RNA test. Now, if somebody's, go ahead.
In people on cabotegravir.
Exactly.
It's important. I just, for my non-HIV experts out there, that these things, the choices are testing for viral particles versus antibody. And there can be a period where you're infected and you have viral particles where you don't have antibody yet, and that's early in the game. But if you go out a ways with something like cabotegravir, and keep testing, the chances of getting an abnormal antibody test versus a real antibody test get more and more likely that you're going to get a false positive, like you said. And so you want to keep monitoring people only up to a point. Once people are on cabotegravir, if they're not infected, they're not going to get infected unless something really weird happens. It's just much more likely that they won't get infected. It's a very effective drug, and I think the same is going to be true. There's a little bit less data, but I think the same is going to be true in June when we have another option. That's going to, lenacapavir is going to be, once you're on it, chances of you getting infected are very small. So I think that people testing early on is important. One of the things that daunts, I think, people who are going to start using PrEP and haven't used it before, who are in the mental health field or the substance abuse field, or seeing people in primary care, is which tests do what. And it's simpler for than it seems. Look for the antibody, look for the virus. A couple weeks later, look for the antibody and look for the virus again. And if you've done it a bunch of times, you're done. One of the things people don't think about is you can get drug levels of drugs. And so if you're worried that someone's not taking their orals, and you're concerned, one of the ways you become concerned is you give them a month's supply, and 2 months later they haven't asked for a refill and they say they're taking it. That's a time when you might sit down with them and say, look, I'm going to test you again because I'm worried. I'm going to test your blood levels because I'm worried. because the goal of this is not to get you infected with something that's resistant. The goal of this is to keep you from getting infected altogether. And patients will respond really well to that, in my experience. I've done that a lot. My patients tend to go off their HIV medicines anyway in the HIV clinic, and then you have to get them back on. And they do that dance regularly because they are busy with the chaos of their lives that you haven't fully resolved yet. 5 years later, you don't have to worry about it. But for the first year or two, often people suddenly become homeless, or their old boyfriend or girlfriend comes back into town or gets out of jail, or they end up in jail for something they did 2 years ago. And when they're in jail, you want to make sure they get coverage.
So just a few other comments about testing, and I like the way you described it. Certainly continuing the antibody testing or fourth generation antibody plus antigen test is essential during use of PrEP, whether it's oral or injectable PrEP. And the frequency really should be guided by, to some degree, by the frequency provider sees a patient, or the convenience to getting to a lab, whether it's every 2 months or every 3 months, or for somebody who's at very low risk but is still on PrEP, even every 6 months may be appropriate for that. Additional tests that are important to get are, especially for sexual transmission of potential sexual transmission of HIV, are other tests for STDs, syphilis, chlamydia, gonorrhea. And the latter, the chlamydia and gonorrhea sites that are tested should be guided by exposure, whether somebody has rectal, genital, or oral exposure for testing for those. Additional tests are really of limited value. For example, kidney function or liver function, or blood tests, blood counts are not recommended in guidelines, or not necessary unless they're being obtained for other primary care or other monitoring reasons. I will mention that individuals with compromised kidney function should be managed carefully. Tenofovir disoproxil fumarate, or TDF, is not recommended for individuals with a estimated glomerular filtration rate less than 60, and TAF, tenofovir alafenamide, not for those with an estimated glomerular filtration rate less than 30. But really, it's a matter of testing if somebody has a new HIV infection with the HIV tests, and testing for STDs. And there's not a whole lot more to monitoring PrEP use, whether it's oral or injectable PrEP.
And very easy. One thing that we haven't talked about is, in these injectable forms of PrEP that are coming, who's going to do the injection? Because that will determine in some settings whether people can use PrEP realistically or not. So how much expertise and who's going to actually do the injecting for cabotegravir, let's say cabotegravir or lenacapavir. You might want to talk a little bit about that, because they are different.
Yeah, for sure. So I think that the number one thing starts with just insurance payment. And since both of them currently are, or cabotegravir is approved for healthcare provider injection, and it's likely that lenacapavir will be approved similarly, although down somewhere sometime in the future, it's likely that self-injection of the lenacapavir will be approved. So starting with the cabotegravir, that's a deep intramuscular injection in the lateral gluteal region, which really does require some skill and expertise for injection with minimal risk of side effects and limited pain. And really, insurance, depending on the insurance cover of the patient, there may be both a healthcare facility fee as well as a medication fee. and that can add a bit of complexity in terms of accessing the medication. With lenacapavir, that is a subcutaneous injection in the abdominal region. It's actually 2 shots that are given at the same time. And that requires less expertise. And as I said, in the future is expected to be available for patient self-administration. But but to your point, Glenn, a system needs to be set up so that a patient can come in for injection with cabotegravir. It should be within 1 week before, 1 week after the injection time. With lenacapavir, within 2 weeks. And if those windows are missed for both of those, there's an oral option that can be taken.
Well,
Go ahead.
one of the things, what message can I carry from an infectious disease standpoint to my substance abuse colleagues, to my psychiatric colleagues, and to the people in urgent care settings and emergency room settings, where a lot of these patients end up coming, who are not HIV infected yet and don't need an HIV clinic. I know that they go to the health department frequently for STDs. One of the things I tell people about is you can get anonymous STD testing in those settings. And that's, for a lot of patients, an important part of getting screened. And but when people go to the health department, that might not be a source of regular care. So I want to get PrEP in all of those kinds of places. What are things that I can do to help people get onto PrEP?
So for the oral PrEP, then simply a prescription and comfort with writing that prescription. And as you've said, establishing a relationship with the individual so they come back both for HIV testing and encouragement to continue their PrEP. In terms of the injectables, starting with the cabotegravir, identifying a injection site, whether it is at a academic medical center. There are also community infusion injection sites that do high volume of cabotegravir in some settings, and then also private infusion injection sites that are involved in cabotegravir injection. And every locale has its own intricacies of that. Becomes a little more complicated for a one-off, but if it's ER or a mental health practitioner who has multiple patients that could benefit, it's certainly worth reaching out even to perhaps ID colleagues to ask where they send patients for cabotegravir.
Well, I also want to give a message to HIV providers that it's important for HIV providers to reach out to these people that we interact with in the community and help educate them about PrEP every chance we get, because they are intimidated by the idea of starting a new practice. It's just like getting primary care doctors to treat depression. It's not necessarily financially rewarding to add to your already busy schedule, but this is an important thing that we have to get people to do. And ID doctors can be essential in helping encourage psychiatrists, psychologists, substance use specialists, nurse practitioners who do this work to get people onto PrEP.
Yeah, I couldn't agree more. And I will try to educate my local colleagues in terms of some of the injectables and how that can be facilitated for patients who I may not be seeing because they don't have infectious disease needs at this point, and I want to keep them from having infectious disease needs in the future.
Oh, is there anything else, Chris, that we really wanted that we didn't cover that we should cover?
Well, I think I'll just mention again the issue of people who miss injections or are minimally adherent to oral PrEP or stop taking PrEP altogether. that remains an important time for follow-up HIV testing if those individuals are still within somebody's practice. And the duration of how long that needs to happen for something like cabotegravir is probably 2 to 4 to 6 months after their last dose. And for lenacapavir, could be even 6 months or longer after their last dose. So continued HIV testing is important, even if the individual no longer has an HIV risk after they take their last injection or last dose of oral or injectable PrEP.
Well, I think those are important things to let people understand also. In the substance abuse community, patients will come into rehab and they'll have been on PrEP, and now that they're in rehab, maybe they don't need it anymore, but maybe they do. Let's try to keep them on it.
Yeah, it's a population. So some of the populations at highest risk for HIV are unaware of that, and I think many of the providers, even expert providers, can be unaware because the patient is not necessarily bringing up some of their risk factors. And when individuals have already been identified as having some risk, either by themselves or by their provider, and have been on PrEP, more HIV testing is certainly always the right thing from my standpoint, because we have many individuals who remain undiagnosed for some time, which compromises their health and increases their risk for spreading HIV to their loved ones.
Well, Chris, it's always a pleasure to collaborate with you. Thank you very much for including me in this, and thank the people who organized this for the work they did to set it up. I think these webinars are very helpful to me in my work, and I hope they're helpful to you. We're now going to have some time for questions for both me and Dr. Hoffmann, but thank you for the wonderful collaboration, both clinically and educationally.
Thanks, Glenn, and I'll certainly remember the consequences versus rewards next time I'm discussing PrEP with a patient.
It sounds so simple. It's so important. People just don't get it that what's important to us is very different than what's important to them. I had a patient say to me once, Dr. Treisman, HIV is not my biggest problem. And if I had HIV, it would be my biggest problem. But it's true, HIV was not this patient's biggest problem. So anyway, the work we do with helping people with HIV is good work, and I'm glad we're doing it. And I like sharing it with everybody. Hello, everybody.
Hello, Dr. Hoffman. Hello, Dr. Treisman.
Hi.
I want to start just by thanking you both so much for such a wonderful discussion. It was incredibly informative, and I certainly got a ton out of both of your unique perspectives, and I'm sure our audience did as well. And speaking of them, thank you everyone for tuning in today. We do have time for some questions, so if you haven't already, please put those in the Q&A or chat box at this time. I'm going to go ahead and open those up right now so I can take a look. So the first question we have is, do you have any strategies or alternative testing to blood tests for those resistant to blood work, like someone who is hard to poke? I'm sorry. It can be hard to get people in for blood work every 2 or 3 months.
I can give that a first stab. So really the best tests for HIV are blood-based tests, either the 4th generation antigen antibody testing or HIV RNA testing. Alternatives to those are the rapid oral test. It is a 3rd generation antibody test, does not have the sensitivity of the blood-based tests. I think going with the harm reduction approach if you can get somebody to be consistently on PrEP and monitoring them that way, it could be a possible approach. I would be very cautious with using OraQuick or the oral antibody testing for HIV with the injectable PrEP because of the lower antibody production with those and greater consequences of ongoing HIV replication with continued use of that PrEP. But with oral PrEP, I think the OraQuick oral buccal swab is a potential, certainly not within any guidelines. But Glenn, I don't know if you have any thoughts on that.
No, I think you've said it perfectly. I haven't had this particular experience of people not wanting to get their blood tested for these things because my patients are pretty used to blood tests. But I imagine that you could use just the antibody test if you had the right patient. Probably would do that. And I also think that just using the two-drug combination oral drug every day is a pretty reasonable thing to do in somebody who has just an oral test. I think that would be okay to do. I would do it.
Excellent. Thank you both so much.
Not everybody is compliant with coming back when you want them to come back either. So the patients that I have the most difficulty initiating in treatment are the ones who come, then relapse, then come, then relapse. And in them, I really don't want injectables. I really want to know what's going on with them. For exactly the reason Chris explained when he's talking about the tail of people. Because I'll often lose somebody for 3 or 4 months or 6 months back to drug use, and then they'll show back up. And I don't want them to have been exposed when their blood levels are very low.
I think that might lead well into the next question that I see, which is, what are some best practices for monitoring adherence to PrEP, especially in populations with unstable housing or inconsistent healthcare access?
Well, you can get blood levels of drugs. That's a thing that can be done. I haven't done that unless really pushed, but you can do it. Usually just talking to the patient about whether or not they're taking their medicines and talking about the many alternatives. We talked a little bit about the idea of taking sort of on-demand, what you might call pre-pro exposure, 2-1-1, whatever you want to call that approach. But it's really for people who aren't going to take it every day, but you want to protect as much as you can. And I think that it's reasonable to talk to them about what they're going to do. I haven't had many patients lie to me about, oddly enough, people tell me the truth about taking their HIV medicines. They don't tell me the truth necessarily about taking their antidepressant medicine. So I'm more likely to get an antidepressant level than I'm to get let's say, an antiviral level, because pretty much people will tell me the truth about that. But they sometimes are very resistant to the idea of taking psychiatric medication, even though they've had a really bad illness. So blood levels are the sort of ultimate. But in between, there are seeing patients more frequently, and the ultimate monitor is whether or not they refill their drug. So luckily, our pharmacy is very available to us, and we can call them up and say, is this person getting their medicines? And that is a very, very effective way to tell other people taking their medicine. If they're not refilling it, they're not taking it. And I tend to give people only a month at a time of medication when they're first starting out. That allows me to know if they really have any commitment to it. But when people show up and I haven't seen them in 2 or 3 months, and I call the pharmacy and they haven't refilled their PrEP, that's a pretty good indication they're not taking it. That almost never happens with HIV drugs. It happens all the time with psychiatric medications. I can't tell you why that is, but people are very reticent sometimes to take medications, even though they've been much better on them. We don't have any trouble with compliance with benzodiazepines and narcotics. They have almost better than perfect compliance. They take a little more than 100% of their medicines. But with antidepressants, anticonvulsants, other drugs, if they see it as a psychiatric medication, they see it somehow differently than their HIV medicine.
Yeah, so I agree with what you were saying, Glenn. One thing that is important to remember, at least with the oral PrEP, is that there are the alternative event driven use, taking 2 tablets of TDF FTC or TAF FTC prior to a potential exposure, and then 1 tablet on the subsequent 2 days. It's something I discuss with all of my patients who are on oral PrEP. And the second thing to remember is that based on data from the Purpose 1 study I mentioned, that complete adherence is great, is optimal, but incomplete adherence can still reduce HIV incidence. And just building a relationship with the patient and helping them discuss their concerns and moving forward. I think that prescribing PrEP in somebody who is not able to take it every day is still within the realm of harm reduction and is still a reasonable approach.
That's fantastic. I think that's all the time that we're going to have for questions today. But once again, I just want to thank both Dr. Hoffman and Dr. Treisman so much for this fantastic discussion, and for answering these questions. I hope everyone finds this information valuable for the future. A video of the presentation will be provided to all attendees and those who signed up for the webinar. So please be on the lookout for that in the next week. At the end of this session, we'll be distributing a survey, and your feedback is very important to us. So we would greatly appreciate it if you could take a moment to fill that out. It'll help us be able to provide more webinars from Unbound Medicine and Johns Hopkins Medicine. In addition to Dr. Hoffman and Dr. Treisman, I want to thank everyone again for attending today. If there are any questions about this webinar or future webinars from Unbound, please contact us at webinars@unboundmedicine.com. Once again, thank you all for attending, and I hope everyone has a great rest of their day.
Thanks to everybody.
Thank you. Thanks, Ben. Thanks, Glenn. And thanks for everyone who's listening's time.